to the inaugural PrecisCa Virtual Breast Cancer Tumor Board. So happy and honored to have our August panel here. I'll introduce them one by one. In fact, they will introduce themselves. First, Dr. Tari King from Harvard.
Thank you. Hi, I'm Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I enjoy taking care of breast cancer patients, and particularly the multidisciplinary approach that we're able to take, and I'm happy to discuss these cases with you today.
Hi, my name is Tom Buckles. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego. I have been at MD Anderson in Houston as a radiation oncologist for 20 years, and I specialized in breast cancer. Love to participate with my multidisciplinary colleagues in the management and research of breast cancer.
Hi, I'm Dr. Bill Gradisher, professor of medicine and chief of hematology oncology at Northwestern University, where I've been for the last 30 years. And I also, along with my colleagues, enjoy taking care of breast cancer patients and the challenges that come with understanding the nuances with each and every case.
Hi, I'm Rennie Butler. I'm Associate Professor of Diagnostic Radiology at Yale University School of Medicine and on the medical faculty of Yale New Haven Hospital and Smilow Cancer Hospital. Looking forward to participating in this panel. I really appreciate the multidisciplinary perspective, and I look forward to presenting the imaging findings, which are really a rapidly evolving technology. And so we'll be discussing how that technology can hopefully be more and more helpful as time goes on.
So Dr. Gradisher, you have this young 5-year-old white female who presented with rapidly changing findings in the left breast following a pregnancy 6 months earlier. Tell us more about her.
Sure. So this was a young woman who detected some changes in her breast shortly after she completed a pregnancy 6 months earlier. And she described increasing erythema or redness, particularly around the nipple areolar complex, that accelerated in the last 2 weeks. She did not breastfeed post-pregnancy. She has no family history of breast cancer, and she had no prior mammogram. She was otherwise healthy. So her physical exam showed the erythema that had been described. It was warm to the touch. The nipple was slightly inverted compared with the right. There were no peau d'orange changes, the dimpling of the skin we sometimes see in these circumstances. And there were lymph nodes under the axilla that were palpable but still movable. She underwent a biopsy that showed triple negative infiltrating duct carcinoma with a very high proliferation rate of about 70%. Biopsy of the skin demonstrated dermal lymphatic invasion, and the axillary biopsy also confirmed cancer in the lymph nodes. Fortunately, when she had staging scans, there was no evidence of metastatic disease on bone scans or CT scans.
So you would call it aggressive because by Ki67, 70%, you mean that when you look under the microscope with special stain, 70% of the cancer cells seem to be divided evenly.
Yes, so that would be the pathologic concern, and then clinically, just the pace at which the skin changes apparently were changing.
I see. So this is what she looked like. Do you want to describe the findings other than what you have already described?
Right. So on this picture, which doesn't show it quite as well, you do get a sense that there is an area of pinkness that is completely around the nipple area and expanding out a couple of centimeters. And the biopsy site was in the left upper outer quadrant of the breast. And the entire area underneath her nipple area and that entire circumscribed area was somewhat firm and warm to the touch around the pink area.
What they call an orange peel appearance, which is considered classic for this type of cancer.
Well, she didn't have the dimpling, but she did have clearly the pinkness.
I see. And you find in your practice that some of these women are diagnosed as infection of the skin and cellulose and given antibiotics, delaying diagnosis further?
Yeah, that's sort of a common story, particularly in the setting where somebody was breastfeeding and they often get treated for, an infection for sometimes many weeks before there's the realization that nothing is improving.
So I guess you would say that to educate people who may be out there, that if breast is red but not tender, that should alert them that this may not be infection and they should seek care
Correct.
from a surgeon sooner.
That's correct. So the rapidly changing clinical picture, married with the pathologic findings, not only of cancer, but the lymphatics being involved, would suggest that this is an aggressive cancer.
So Dr. King, see these cases as well, and in your experience about this presentation, and what would you audience?
Yes, thank you. So certainly inflammatory breast cancer is one of the most aggressive forms of cancer that we see. It certainly is a presentation that requires, again, multidisciplinary care. As you mentioned, sometimes the diagnosis can be delayed, and particularly in young postpartum women, because it can mimic infection. But certainly, even if a course of antibiotic is tried, it should certainly only be one quick course, and without any evidence of improvement, then the patient should be referred for breast evaluation. Often mammography is not very illustrative of the underlying disease process in these cases, because it does tend to be diffuse through the breast. And so this is a place that we do use MRI quite frequently in helping us to understand the extent of disease. Understand if there's chest wall involvement, have a look at the lymph node basins, etc. Patients who have inflammatory breast cancer should receive upfront systemic therapy. They should receive preoperative systemic therapy. It's considered inoperable at the outset. You would not take a patient with inflammatory breast cancer directly to surgery. But thankfully, the majority do have a good response to preoperative therapy, and they are then able to proceed to surgery. And the surgery should remain a modified radical mastectomy. There is no prospective level 1 data to suggest that you can do anything less than a mastectomy in the setting of inflammatory breast cancer. There is no good data to suggest that you can do a sentinel node procedure in the setting of inflammatory breast cancer. So mastectomy and lymph node dissection remain the standard. And we do not offer immediate breast reconstruction in the setting of inflammatory breast cancer, because the skin, as was noted on the biopsy, is involved with dermal lymphatics. You want to optimize, again, the systemic therapy to treat that disease, but you also want to remove as much of the previously affected skin as you can at the time of surgery. So you cannot leave a skin envelope for breast reconstruction. So we perform mastectomy without reconstruction. And then, as Dr. Buchholz will discuss, all of these patients are candidates for comprehensive chest wall radiotherapy to achieve the best both local regional outcomes as well as survival outcomes. These women have a very high risk of local regional recurrence as well as distant recurrence.
Well, thank God it's an uncommon scenario. And before Dr. Buchholz's comment, the first line of treatment, as we all agree, is systemic. Dr. Gradishar, what would be your typical treatment regimen for this type of patient?
So it's usually an anthracycline-based regimen with consideration of a platinum, possibly, certainly if the patient has triple negative disease. And again, immune therapy is being evaluated in this setting. So depending on whether there are markers that suggest the patient might benefit, she could very well be eligible for a clinical trial.
And what makes you decide about platinum?
Well, I think if a patient has triple negative disease and is younger, it would be a consideration. The data is not completely consistent with using platinums in a preoperative setting, because what you want to be able to demonstrate is that the presumed PCR rate that goes up with adding more drugs translates into a better outcome. It should also be pointed out too.
Sorry, I interrupted you, but I just wanted to explain PCR for those who don't know what that is. That when you look at the tumor after surgery under the microscope, that there's no tumor cells alive in the specimen. Go on, sorry to interrupt you.
No, so I think the issue with these very aggressive tumors is more going to be better. It's sort of the approach that medical oncologists always use, is make the cocktail more complicated, but will it translate into a better overall outcome? And one of the issues also is that depending on what the outcome is at surgery in terms of what disease is or is not in the specimen may dictate whether the patient gets additional chemotherapy or other treatment options post-operatively.
Bill, you had mentioned anthracyclines preoperatively. You would also include taxanes? Is that true?
An anthracycline taxane regimen.
Yeah.
The only question would be whether a platinum is added to it.
Correct. Okay. This is Tom Buckles. With respect to the local regional management, Dr. King so eloquently stated the surgical approaches, which I'm in complete agreement with. I think it is very important to proceed with a modified radical mastectomy. Sometimes, again, in the community, you can see these cases approached with the skin sparing technique, which we feel are contraindicated because of the dermal lymphatic involvement, can extend the disease well beyond the typical appearance of non-inflammatory breast cancer. Similarly, all these cases receive adjuvant chest wall lymphatic radiation following their surgery. For the same reasons, we tend to make the fields a little bit wider and more extensive. We're very careful at looking at the preoperative extent of disease with high quality medical photography to assure that all areas of potential skin involvement are included in the radiation fields. And we treat to the skin a little bit more aggressively, bringing the dose to the skin higher. So unfortunately, during the course of radiation, patients can expect to have a really brisk, acute radiation-induced dermatitis. We almost want to see that because the skin is a particular target in inflammatory breast cancer, in addition to the usual targets that we include with post-mastectomy radiation.
Great. So what is the normal expectation of local recurrence in these patients after all this treatment?
I think the local recurrence with modern day approaches is really quite good if you do combination of systemic treatments. There are some people where local recurrence is still a problem, namely those who respond very poorly to their preoperative chemotherapy. So if they have a significant residual cancer burden following the anthracycline and taxane chemotherapy, if Dr. King has a challenge of getting around this completely, if there's a positive surgical margin and significant residual disease, those are instances where local regional recurrences still are a problem despite using post-mastectomy radiation. And these cases can even recur rapidly after surgery before radiation started because of the aggressive biology if they fail to respond to systemic treatments.
These are also cases where women are fearful. They have this aggressive disease, and they often want to talk about removing the contralateral breast. And these particular cases are really important to try to focus the woman on the disease that she presently has, and not to introduce any potential increased risk for complications by doing contralateral surgery, not to potentially increase the likelihood that she would be delayed getting to her radiation due to complications from bilateral surgery. Again, we said that we do not offer these women immediate reconstruction, but if they do well, completing their radiation and a year after treatment are still doing well, then certainly they should be referred for consideration for delayed reconstruction. And when they are having that conversation about the option of delayed reconstruction, if at that time, they are still concerned about their risk of contralateral disease, or if there's a discussion that is had around risk of contralateral breast cancer, we can revisit that contralateral breast at that time. It's really important to focus these patients on appropriate therapy for their current cancer and to not get distracted by the contralateral breast.
Yeah, that's very important and very well. So, Dr. Gradishar, your considerations for genetic testing in this type of case?
Well, we would definitely do it. I mean, again, it's a younger patient. It may dictate, genetic testing not only, of course, can aid you in surgical decision-making regarding the involved breast and the contralateral breast, but should the patient develop metastatic disease, we now have therapeutics that are useful depending on whether or not genetic abnormalities are present. So in other words, PARP inhibitors as an example. And some of the other things I mentioned there, I think Dr. King pretty dogmatically said that there wouldn't be any consideration other than doing a mastectomy, although I've heard, anecdotally that there are some people who think if you get a really good response, maybe something less than that could be done. But I think that the dogma remains that this is aggressive disease that warrants, full press surgery, radiation therapy. And, the only other point I would make is depending on what the pathology specimen showed at the time of surgery would dictate whether additional therapy, post neoadjuvant residual disease therapy, would be considered, be that capecitabine, be it a platinum. There are several trials looking at immune therapy in this setting. So there may be other options that this patient could consider. And I think, as the others have said, one of the biggest issues is less about the local recurrence risk and more about the systemic recurrence risk.
So Dr. King also said that she would prefer not to do bilateral mastectomies, this type of patient, if I understood her correctly. So if she has BRCA2 mutation, Dr. King, you would still do 2 separate operations?
I would, particularly BRCA2 mutation carriers. Actually, their risk of contralateral breast cancer is not increased in the first 5 to 10 years after treatment for index disease. It only becomes increased 10 years and beyond. And so, typically in BRCA2 mutation carriers, they also have ER positive disease. So there would be also protection against that contralateral breast cancer risk. So again, there are many other mutations out there that could put women at increased risk for contralateral disease, and it's important to understand the level of that risk and the timing of that risk. And if patients with inflammatory breast cancer experience a long disease-free interval without the development of metastatic disease, then there is certainly time to come back and talk about that risk of contralateral breast cancer.
Great. So you would not be talking about the mastectomy with this type of patient?
Not at the outset. I would really focus them on, again, completing their comprehensive therapy. We know that bilateral mastectomy increases the risk of operative complications. That can delay people getting to comprehensive chest wall RT if there's a problem with wound healing. On the contralateral side, we don't want that to delay her getting to her complete treatment for her index cancer.
So finally, these considerations that we have up on the screen, second to last, if there's less than a clinical complete response, Dr. Buchholz, would you like to do something preoperatively to help out the poor oncologist, or would you ask the medical oncologist to find another regimen to switch to?
This, I think we'd have to see mostly with our surgical colleagues. We would evaluate the patient upon completion of the best neoadjuvant chemotherapy course, so both the anthracyclines and the taxanes. If they had a poor response, I think it becomes a question about their operability. And if we like to try to achieve a negative surgical margin, And so I would probably see the patient jointly with Dr. King, and we could assess whether we think the patient has operable disease. If there is operable disease, we probably do surgery followed by radiation. There are some instances that are kind of marginally operational, where we could consider doing preoperative radiation followed by mastectomy. And there are some cases where there's clearly inoperable disease, in which case we do radiation either with some concurrent chemotherapy, which really hasn't been proven to be overly effective. By this case, by this situation, it almost becomes one of palliative treatment if they're not responding at all to their systemic treatments, because definitive radiation alone is not the optimal way to go for local regional treatments.
Excellent. I think that's great.